Digital quality measurement promises better measures with less burden. But how do we get to that better future? Today, we speak with Rebecca Jacobson, a physician informaticist and the CEO of Astrata, a digital quality company that helps health plans and ACOs transition to digital quality measurement. Rebecca, welcome to Quality Matters. We appreciate your being here.
Thanks so much, Andy.
What do you find people in the industry don't know or get wrong about digital quality measurement?
Many people think of it just as technology, and it's more than that. It's better to think of it as a fundamental shift. There's so much socio-technical, sociological, organizational change required for an organization to make such a shift. Clearly, the work that individual people do has to change. The way programs are organized has to change. These are things that require change management and organizational understanding about the difficulty and the amount of time it's going to take to transition. It can't be done in a quarter. It can't be done in 1 year.
You and I met recently at the NCQA Industry Council meeting where you made useful observations about the industry's readiness to transition to digital. Recap for us, where does the industry's readiness for digital transition stand?
It's mixed. Elements of healthcare organizations, payers in particular, we've seen tremendous progress to take on digital quality, especially access to clinical data. That has greatly improved the last several years. The comment I made at the Industry Council was about how to make the business case, the financial case for digital quality. There are still organizations struggling how to do that, how to convince a chief financial officer in the midst of a difficult year for health plans, how to understand and quantify the value that comes from digital quality. It's a complex topic and it's difficult to reduce to a single number. There is significant value, but it remains challenging to quantify. The business case, I would say right now, is our biggest sticking point.
Why isn't the value obvious? Digital on its face sounds better than manual. What's the problem?
It does, and usually it is. However, the cost of moving to digital is significant. At this point, with so much changing in terms of risk adjustment, the medical expense ratios that many health plans face, there is resistance to doing things prematurely. There might be concern, it's early, maybe we should wait. I don't think that's true. This transition will be challenging and it's going to take time. But the benefits, once you make that change, are substantial in terms of how quickly you'll be able to get this data so that you can improve quality. As organizations stand up to make this change, I think they will see the financial returns they're looking for. At the moment, they're trying to figure out, how do I put that into a spreadsheet and show a return on investment before I make these investments? That's been challenging.
And what is at stake if plans don't make this transition?
So a lot of things are at stake. One thing at stake is quality bonus payments, and that is important both to health plans and providers that benefit from quality bonus payments. The other thing that's at stake is, just to accomplish a transformation like this, it's best to be earlier. It tends to go better. You have more time, you have more access to experts, you have more time to educate your staff about what's going on, so you'd achieve a better outcome. And that outcome is important because the understanding of your population is fundamental to what a health plan has to do.
Back to the idea of what's in digital for a CFO at a health plan. Why would a health plan CFO sign off on a digital quality measurement?
It really is about measuring complete compliance and assuring that you are getting a fair rate that's going to translate to the appropriate quality bonus payments, but it goes far beyond that. Digital quality measurement enables us to improve healthcare quality during the measurement year, which is when we can improve healthcare quality. That gives us a much faster cycle. If we think about like a learning health system that is constantly changing and morphing as we get more data, it gives us really a fighting chance at becoming a learning health system because we have the data when we need it.
That's interesting. A fighting chance at becoming a learning health system. What's the problem now? People say, I learn, I get better at my job.
And we do. Absolutely, we do. But to improve at the scale that we need to improve, at the speed that we need to improve, we need data much more readily, with much less friction, at much less cost. Some measures where it's difficult to know what's going on until the end of the year. It's a challenge to get better on those measures. And even beyond that, we all hope for measures that measure what we want to measure, which is outcomes. Digital quality opens up the potential for better, more informative measures that will help us in improving our healthcare system.
Let's talk about timing. What time frame do you think most financial people in the industry are thinking of? And what do you think their time frame should be?
CFOs have such a hard job, especially these days, under such pressure. And it makes perfect sense that CFOs are worried most immediately about what's going on right now. They may underestimate the work necessary to produce this transformation in their organizations. At Astrata, we use what we call a digital quality maturity model. And this maturity model spells out how to start, what to do next, what's the sequence of things you should be working on, and it anticipates 2030 as the switchover where you need to have everything done. We think that should take between 4 and 5 years. We're coming into the end of 2024. Now is the time to be putting in the investment enough to get started so when the time comes, you do have the maturity to switch.
How has your thinking about the timing of the digital quality transition changed over the years?
One of the things that surprised me is it has taken longer. It's been slower than I anticipated 10 years ago. I looked at how much better it was going to be and thought it seems like a no-brainer. It seemed so obvious that this was the right thing to do. And we saw leading health plans, five-star plans moving towards this. But of course, there are competing priorities in healthcare, and change in healthcare is always slow. So I guess that shouldn't have surprised me. And healthcare has been through difficult times with COVID. A lot of things have pushed back in the other direction. I think we are going to overcome those. We're going to pick up speed.
And do you feel like the delays have been more a matter of will, skill, something else?
It's multifactorial. Some of it is will, how we position the value. People have to know this is going to help in the long run. It's going to help our members. There's definitely a skill part. Many of them are new technologies. How does a health plan think about a fire strategy, for example, for their data? They've had some experience with that, with the interoperability requirements, but maybe not as sophisticated as what's required for quality. This is a multifaceted change, and these things are not necessarily synchronized. This degree of industry change requires a lot of synchronization, that when the health plan is ready to do X, that thing already exists. So those things have all of them have kind of slowed us down.
I asked other experts at NCQA for their opinion.
Hi, this is Brad Ryan, Chief Growth Officer at NCQA. Sounds like Rebecca's view as organizations are viewing the shift to digital as a win and not an if. I would agree with that. Most folks we talk to say, I get it. I want to go there. The question is when and how. And that's a hard problem for NCQA to navigate. And we're working to engage with stakeholder communities, including our digital community, to get feedback about what people need. For example, our digital hub has resources for organizations that are trying to plan their digital journey. We know it won't be everyone at the same time. We have to create a framework where organizations can go at a pace that suits them so that we all get there eventually. That's what we're doing. Is the resources you'll find if you go to our digital hub. There's ways to learn data mapping, starting to work with digital content. Before you make the full cutover, a lot of organizations should be thinking about it. How do I plan for my cutover? At this point, if you don't have a plan, if you're not working on a plan, you're probably behind because this is happening.
You are a member of the National Quality Forum's AI in Quality Measures Technical Expert Panel. Three ideas: artificial intelligence, natural language processing, and machine learning. What is the relationship between those three concepts as they relate to quality?
Artificial intelligence is machine-based methods that kind of simulate or reproduce intelligence, and they can include NLP and machine learning. What is natural language processing? Natural language processing, you can think of as mimicking what a human reader would do when they sit down with a chart and the definition of a measure. Natural language processing is using computers to read, similar to what a abstractor does, and extract information relevant to a quality measure to determine whether someone is compliant. In other words, I have a chart for a member. I'm going to take that measure definition and apply it. I'm going to read the chart and see, is there anywhere this member would fit this measure? Instead of doing a sample, they on a smaller number, they can use natural language processing as a first reviewer. It means you can start with 1 million members and quickly narrow it down to just the ones you need to look at. Machine learning is a set of methods that could be used to predict or triage members for intervention. For example, it uses statistics and mathematics to derive patterns out of the data that tell us something predictive about what's going to classify somebody as more urgent to intervene with, let's say. Machine learning doesn't require pre-existing knowledge. I don't have to go in and make rules in advance. Rather, I use statistics to look at the data and derive that decision without coming with pre-decided variables.
Since the digital transition has taken longer than you thought it would, do you anticipate that incorporating AI, machine learning, and NLP will be even more prolonged, more drawn out?
Surprisingly not. In some ways, they're easier. Take NLP as an example. As a whole, getting data as a chart from an electronic health record isn't very hard. You can go in and kind of download it yourself if you want, right? Just get the entire chart, the entire thing as text. NLP methods help you take a vast number of charts and whittle it down to a small number that you need to review. It may be easier. And I say that is a bit of a bridge. It helps you make the mental transition, getting your team to understand what does it mean to be measuring during the measurement year and improving quality during the measurement year. Just getting that fundamental foundation is a huge help to digital quality.
Here again, Brad Ryan of NCQA.
With regard to Rebecca's comments about natural language processing helping us through this transition, I would add this might be the best first clinical application for artificial intelligence. We have done a good job as an industry of digitizing clinical data. We have done a terrible job standardizing what was collected and shared in that data. And artificial intelligence and natural language processing are a efficient, scalable way for us to take unstructured, non-standard data into a standard format. That is the biggest lift. The real work is this data mapping to standard data. If we can get AI and NLP to be the frontline workers for that data mapping, that takes us forward into the future, tens to hundreds of times faster.
I was thinking a health plan CFO that might be reluctant to greenlight the transition to digital now might think, well, if NLP is already happening, can we just do that without the digital? Possible to do some of this without doing all of it?
It's not recommended. Whenever you're making a huge transformation, it's composed of a bunch of smaller transformations. And it's easier to take one bite of the elephant than try to eat the whole thing. Get started, do something, you take a smaller transformation, work on that. To have real success in a time as short as we've got to make this transition, to succeed in value-based care and to make that work, a lot has to change. And one of the things that has to change, and to make it work financially, is it's going to need to be highly choreographed. Places that are serious about doing it have their leadership involved, technical and quality and operations, and they are focused on doing things in the right order so they're able to meet the deadline they're imposing on themselves, which is often before 2030.
Let's talk about the rose, the thorn, and the bud. What is the rose, or what's going well these days in digital quality measurement?
The biggest thing is access to data has improved. If I look back 5 years, there was very little clinical data being used by health plans. They were still predominantly using claims data. One of the big steps forward was the ability to use a CCD, a continuity of care document. That is a format that allows us to get predominantly structured data from an electronic health record, for example, a series of blood pressures or A1C results. That was a big step forward because now you could get data from electronic health records from your provider network and use that to close quality gaps. The next big advance was NCQA's digital data aggregator validation program. Took that CCD, made it much more of a standard, gave us a standard way to ensure that this was being processed correctly, that reduced some audit requirements of this structured data. Big advance. The Office of the National Coordinator, ONC's interoperability requirements started to move health plans to use FHIR data, understand, what is a FHIR server? How do I use it? How do I transform this data for a selected use cases? Another big advance. Taken as a whole, a health plan's sophistication and ability to use clinical data has improved dramatically. So the rose is our ability to access and to use data.
Speaking of data, Brad Ryan adds that even plans that think they aren't ready for digital measurement are better prepared than they may think.
People think, well, I don't have access to the data to do digital quality. The fact is, if you had the data to report on a measure last year, you have the data to work with a DQM. The only gap is a mapping exercise because these DQMs use standard data models that may not be in your current stack. And so people think they have a problem of not having access to the data. In fact, they just don't have the data mapped appropriately to data models that they need. And those are different problems.
Brad also picked up on what Rebecca said regarding NCQA's data aggregator validation program.
I like what Rebecca was saying about data aggregator validation and the way it helped us as an industry standardize the way data is collected and shared through CCDs and now through FHIR. Those standards streamline data operations. Once we're doing electronic standards-based exchange of data, we can take elements of the validator program that are helping people trust the accuracy and completeness of data they're exchanging and automate them. There's what we call primary source validation, where information has to be checked to the source, often in an electronic health record, and someone has to go look at a screen and verify the data matches the record. It remains a manual, high-cost process. Now that we have CCDs and FHIR, we're exchanging standard data, you just automate that to take the manual elements out of it. It won't be completely automated anytime soon, but you can make it more efficient. The data aggregator validation program is a necessary step towards those validation methods.
Let's move on to the thorn. What would you say is the thorn or the sticking point in transitioning to digital quality?
The thorn is we don't yet have a crisp vision of the end state and how to get there. Here's an example. Most health plans have a vended HEDIS engine, and they often have their own HEDIS engine, an internal one. They use maybe for state measures, maybe for custom measures, etc. What we don't want to do is to add a third type of engine because they can't support it. So the future of digital has to subsume traditional measurement and not just measurement for HEDIS and for NCQA, but also state measures. One engine must be able to do all of these things. A digital engine should be the basis for all of these types of measures. But whatever it is not just adding more things on top of what we already have. It is removing a number of the things that we do right now and replacing them with a better way of measuring, which is digital quality measurement.
What or where is the bud in digital quality measurement? In other words, what or where is the emerging possibility?
I would say that it is natural language processing and AI. Methods like natural language processing have an opportunity to bridge the gap from where we are now to where we need to be. I don't know that it's a replacement, but it could be an accelerant. It's not just about reporting. It's about improving healthcare quality. Measuring quality traditionally has been the focus. It's been about producing the quantitative results and reporting them to a federal or state agency. Because of that, because so much effort had to be put into doing that properly, and because in many cases it was somewhat retrospective, it has limited our ability to respond with the timeliness that we need to really be able to improve quality. And that's the place where we see obviously real value. It's in making healthcare better and improving the outcomes for people.
Is there anything you would like to advise our audience to do? And do you have an ask of our audience?
The place to focus is educating your leaders and your teams, educating executive leadership group, including your CFO, explaining why this transition is going to come, and it's better to be in control of the transformation and derive maximum value and not behind. Educating your teams is important because it takes time. It really does take time for teams to understand what is different about using clinical data, what is different about doing this during the measurement year, where is the benefit, where is the opportunity. I'll tell you, I've been surprised by the wonderful ideas that come from on the ground teams about how to use better data to advance programs that they have, to invent entirely new programs. So that's both my guidance and my ask. It's really about education.
And then final question, if you could erect a billboard that people in healthcare quality measurement would see all the time, what would you want your billboard to say?
I'd want my billboard to say, digital quality, you can do it. Big things like this, big transformations that impact so much of the organization. They can be daunting, but we've seen plans make substantial progress who are clearly going to do very well. It can be done. Every quality team has it in them to guide this transformation and derive benefit. Just start now and have the confidence that you're able to do it, that there are a lot of resources to help you. I mean, NCQA has a lot of resources, for example, and get started now because it's going to be easier once you get moving.
Good. Well, Rebecca Jacobson, CEO of Astrata, thank you for joining us on Quality Matters. We appreciate your being here.
Thanks so much, Andy. I really enjoyed it.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.